Good morning, everyone, and Chodesh Tov. Thank you so much for joining us for Spirit, the stimulating program initiative for retirees that inspires thought. I'm Judy Steinig, Director of Community Programs for the Orthodox Union, and it's my honor to coordinate and host this program. Spirit was started several years ago by the OU as an on-site program, and now we're happy to present it as an online program for baby boomers, active retirees, not yet retirees, empty nesters, sandwich generation parents, and seniors. Everybody who's looking for opportunities for educational, intellectual, and spiritual growth. Since we all continue to shelter in because of the pandemic, Spirit has become the perfect way for everyone to engage in a virtual setting. The Spirit program has recently become acquainted with the education outreach efforts of Weill Cornell Medicine from New York Presbyterian Hospital of Queens. We have appreciated their assistance in connecting us with some of their experts on various health matters that affect our Spirit demographic. Today, we will be addressing lung cancer in our community during the time of COVID, and we are honored to have a presentation by Dr. Oliver Chow, an attending thoracic surgeon at New York Presbyterian Hospital of Queens, and who is also an assistant professor of clinical cardiothoracic surgery at Weill Cornell Medicine. It is my privilege to welcome Dr. Chow to the Spirit Forum. Thank you, everyone, for joining us.
Hi, good morning, everyone. Thank you so much for inviting me to speak to the Orthodox Union. It's my pleasure to be here. Again, my name is Oliver Chow, and I'm a thoracic surgeon at New York Presbyterian as well as New York Presbyterian Queens. I'm going to pull up my slides. And the way that we'll structure this morning is I have a presentation, and I believe we'll have some room for questions that can be placed in through the chat or sent to Judy during the course of the presentation. So most of us at some point or another have come across a family member or a friend who has encountered lung cancer or will face a diagnosis of lung cancer at some time ourselves. And if I could send us all away with just one thing, one or two things from this presentation, it's two main messages. It's that one, lung cancer is treatable, and every year there are many new therapies for all stages of lung cancer. And two, lung cancer can be caught and cured early, especially in those who are known to be at high risk. So to start off, I wanted to discuss just what lung cancer is at its core. And as probably many of you already know, cancers are abnormal cells that grow, in this case, inside of the lung. These changes are driven by mutations within those cells that change the behavior and the normal workings of regular cells. Like many other cancers in the body, as they grow, they begin to destroy and displace the tissues that surround them. And this is what happens in lung cancer. And as they continue, if they continue to grow unchecked, they can continue to change, and some of these cancers can acquire the ability to spread and implant themselves elsewhere in the body. For the purposes of lung cancer, the most common places that they'll spread is the lymph nodes within the chest, as well as the bone, the brain, the liver, and the adrenal glands. Many of us are familiar with some of the risk factors associated with lung cancer. Age is an important risk factor of lung cancer. Lung cancer is less common in individuals during their younger years, but especially as we get to the point of being over the age of 65, lung cancer becomes much more prevalent and becomes more common. We all know that smoking is an important risk factor to the development of lung cancer. But along the same lines, secondhand smoke and other inhalational exposures also increase the rate of lung cancer. Anyone who's had a lung cancer previously is at a much higher risk for developing new lung cancers in the future. And that's why if someone is treated for lung cancer, we watch them very closely, oftentimes for the rest of their lives, just to make sure that if they develop a new lung cancer, that we can potentially treat it earlier before it causes more damage. Some people have a very strong propensity for developing lung cancers based on their family. And if someone has a lot of family members who have had lung cancers, we'll oftentimes be a little bit more keen to watch them more carefully. And then there are other exposures like radon in our homes and radiation from other treatments that can also increase the risk of developing lung cancers. So I wanted to discuss and frame how dangerous lung cancer actually is. And I think we've received a lot more attention in more recent years because the fact remains that lung cancer causes more deaths than any other cancer, about 130,000 in America alone. More people die from lung cancer than from the three other most common cancers. So breast cancer, prostate cancer in men, and colon cancer. More people die from lung cancer than from all of those other cancers combined. One of the reasons lung cancer is so dangerous is because it can often grow for many years without actually causing any symptoms. And that's why a lot of times when we find lung cancer, it's already spread outside of the lungs itself. How big a cancer is in terms of its actual size and whether it has spread determines how dangerous it actually is. I've put up the 5-year survival percentages of lung cancer when it's remained local within the lung or regional inside of the chest or spread outside of the lung. But I think if there's one thing to recognize, it's that whenever I meet someone who has lung cancer, I really try to emphasize that they're being faced with a new diagnosis that's very scary, but it's very difficult to make strong predictions about how long someone has or how well they will do with lung cancer treatment until they actually start treatment. So even in the most advanced cancers, especially nowadays, we see some very amazing responses with some of the newer therapies. And so if someone is willing to start treatment and they're in good health to do so, my personal leaning as a clinician is certainly that it's worthwhile to at least initiate therapy because there are a lot of new advances and new treatment options for lung cancer. And I'll go into those a little bit more later. But it's also important to note that the majority of lung cancers, when clinicians and patients are diagnosed with lung cancer, the majority are in a stage 4 setting, advanced lung cancer that's spread outside of the lungs. The symptoms of lung cancer are pretty broad, and there are a lot of different symptoms that can occur. Sometimes it's none, as I mentioned. Lung cancers can grow without anyone knowing that they're there. Sometimes, especially depending on the location, they become, as they get bigger and they destroy some of the lung tissue around, we start seeing more symptoms. And so the symptoms can be anything from a cough, blood in the sputum, so coughing up with a little bit of streaking inside of the phlegm, repeated lung infection. Some people just get a pneumonia over and over, and that can be a symptom of cancer sometimes. Having more chest pain or difficulty breathing, experiencing a change, a sudden change in their voice to become a more hoarse voice, changes in appetite or energy or weight. All of those can sometimes be indicative of something that's happening inside. And in some cases, bony pain and headaches can also be symptoms, oftentimes because those represent symptoms that occur when lung cancer spreads outside of the lungs themselves. I think it's important to at least touch upon the fact that now, especially with several large clinical trials across the country and also other trials internationally, we've actually been able to show that screening patients for lung cancer, especially those who are at high risk for developing lung cancers, is very effective and can oftentimes find lung cancers at an earlier stage when they're easier to treat. So screening for lung cancer at the current time is eligible for patients between the ages of 55 and 74. And for patients who have smoked a fair bit in their past. So what we look for is whether or not they've smoked approximately 1 pack of cigarettes per day over the course of 30 years, and are also a current smoker or have quit more recently within the past 15 years. And these patients are eligible to receive a CAT scan every year to look for abnormalities in their lung. And screening for lung cancers has been so successful in finding some early stage lung cancers that we're soon going to be broadening that screening eligibility, so that even patients who are at a younger age and who have smoked less will be eligible to receive this type of screening. When someone's diagnosed with lung cancer, a number of things start rolling into action in order to try to figure out the best way of helping them treat their lung cancer and to hopefully get back to regular living. First, doctors will obtain images that show the cancer and will need to make the determination as to whether or not the abnormality actually is a cancer. And this is oftentimes done with a biopsy. Second, the doctors will need to determine whether or not the cancer has spread elsewhere in the body. And this is oftentimes done with something called a PET scan or a PET CT scan. Basically, it's a series of X-rays that look specifically for cells that are more active than usual, which are more likely to be cancer cells. Sometimes there are other procedures involved with this process of staging the lung cancer as well. And then next, a team of doctors, usually a combination of doctors, which can include a pulmonologist, a medical oncologist, sometimes a radiation oncologist, and a surgeon like myself, will discuss and decide how best to treat the lung cancer and discuss that with the patient and the patient's family. And then we begin treatment. And next, fourth, is after the treatment of lung cancer. There's an important role of making sure to have continued regular checkups and CAT scans to make sure that the cancer is not coming back or spreading after treatment. And while this is a general framework for the steps that are taken when a patient is diagnosed with lung cancer, it may not necessarily be linear. And sometimes the position of the cancer or how it is acting might change the order. And that's important to note as well. When it comes to the treatments for lung cancer, surgery is important. I'm a thoracic surgeon, and I'm always glad to be able to treat a cancer with surgery because when a cancer has not spread outside of the lungs, it is a great option and can potentially be curative. Radiation plays an important role in lung cancers. It can destroy the cancer cells in a very targeted way. In some cases, it can provide a cure as well. It's also a very good option, and sometimes is the best option, especially when someone might not be the best candidate for surgery because of other medical conditions. The medications when it comes to treating lung cancer are very plentiful. And while it used to be the case that there were only several agents that we could use to treat lung cancer, especially after it had spread, the past couple of years has really been transformative because we have many new agents in terms of things that you may have heard of, immunotherapy, which are medications that work with your body's immune system to fight cancers, targeted therapies, which are specific medications that work on specific cancers based off of their mutations. And then also the traditional chemotherapies, which are and oftentimes can be very effective because they destroy cells that are dividing quickly, which are likely to be the cancer cells. And often, especially in lung cancer, the treatment involves a combination of all of these different treatments. I wanted to discuss for a little bit just what surgery is like for lung cancer. Generally, surgery for lung cancer is done by a cardiothoracic surgeon. As a thoracic surgeon, we receive specialized training to operate on the lungs. There's a lot of important structures inside of the chest, and thoracic surgeons generally have been trained, especially nowadays, to use minimally invasive techniques to allow patients who are receiving a surgery for lung cancer to recover faster, have less pain, and make sure that they receive a very thorough and appropriate lung cancer operation. Most lung cancer surgeries can be done minimally invasively. This is with several small incisions, each about the size of a fingernail. And a thoracic surgeon, like myself, would work with a combination of camera and thin instruments to remove the cancer from the body, sometimes with the assistance of a robot. The stay in the hospital is usually somewhere between 2 to 4 days after an operation like this. And if a patient is still working at the time of their operation, they'll usually need to take somewhere between 2 to 4 weeks off work. Sometimes to do the operation safely or to remove a larger cancer, a larger incision called a thoracotomy is required. And patients can still recover very well from this type of surgery. Usually the differences are that they'll receive an epidural to help with their pain control, and their hospital stay will probably be several days longer, somewhere along the lines of 4 to 6 days. After surgery for lung cancer, patients can expect to be woken up. They'll be able to eat, move around the same day as their surgery. They'll receive medications in order to treat pain and have devices to help them exercise their breathing. After a lung cancer operation, someone can expect to have a thin tube that comes in the side of their chest where they were operated on. And that tube is meant to simply drain air and fluid while you heal and the person's lung heals after surgery. They'll receive x-rays to make sure that things are healing as expected. And then once the chest tube is removed, patients are generally able to go home the same day or soon after, just as long as they're breathing well and their pain is well controlled. I wanted to touch upon what lung cancer is like in the Jewish community specifically. There are some genetic risk factors that appear to increase the risk for developing lung cancers, especially in certain families. There's been a lot of research more recently on a gene called ATM, and variations in this gene have been found to be more common in lung cancer patients. And so it's thought to be something for Jews of Ashkenazi descent that may predispose them to developing certain lung cancers. This is a reason why if you have numerous individuals inside of your family who have faced lung cancer, you may indeed actually have an elevated risk profile. And so it's worth seeing whether or not you might be eligible for any screening. But actually receiving screening, this area remains an area of active research. It's not something that is routinely recommended nowadays. Because there are many different mutations that can make some cancers more responsive to certain therapies than others, it's important for, again, a team of physicians, both medical oncologists and radiation specialists who might be familiar with some of the newer therapies and newer research to be involved in the consideration of the treatment of your lung cancer. There have been a lot of innovations when it comes to treating lung cancer, especially over the past 4 to 5 years. And that's why when I put up those survival percentages before, I think the important thing is not to take away just how bad stage 4 and lung cancer is once it's spread outside. The important thing is to recognize that lung cancer and the treatment for lung cancer is changing every single year right now. Mutation analysis is very important in terms of how we treat lung cancers now. They can help deter, by looking at the actual genes that have changed in a cancer, we can determine how best to treat a particular type of lung cancer. The way we identify mutations in cancers can be from the tissue of the cancer itself once we've removed it or biopsied it. But some cancers, and especially for lung cancer, we can just take a vial of blood, and in that blood, there are oftentimes circulating tumor cells. And from that, we can identify whether or not someone's lung cancer has a particular type of mutation. And so this is pretty commonplace now, and especially um, um, in, um, in pretty much any setting now, these things are available as part of the analysis of a new lung cancer. There's also a lot of combination therapies and newer medications. And so each year we're having new research trials show the development of new drugs and new therapies. And more and more patients who have lung cancer will start seeing that their treatment is not just one modality of treatment. They'll have a combination of treatments and therapies that have been shown to provide better results for lung cancer and really increase patients' longevity and ability to live with lung cancer. There are also more options for patients who are not eligible for surgery. So if someone just doesn't want surgery themselves or are too sick to receive surgery, there are more options available to treating their lung cancer than there used to be, both with a combination of radiation, radiofrequency ablation, cryotherapy, and there are newer treatments coming down the pipeline as well. From the surgeon standpoint, we use different techniques as well. Not only are we more equipped and more well-trained to do minimally invasive surgery nowadays, but surgeons oftentimes, like myself, will use robots in order to allow us to work with more dexterity and precision and to improve the surgical technique so that patients get the best cancer operation possible and recover faster. I'll take a brief moment just to talk about some of the newer therapies, but again, this starts getting complicated very quickly, and so I'll try to keep it relevant. When it comes to immunotherapy, the thing is that lung cancers, our immune systems are pretty amazing. They're going out through our lives. They're identifying, removing, fixing cells that may have been damaged or altered in even minor ways. When it comes to cancers that are growing, generally what happens is that the cancer has found a way to hide from our immune system or even subvert the immune system so that it doesn't actually attack the cancer. And this is one of the big problems that happens, and this is why a cancer can grow unchecked. Immunotherapies are a number of different medications that have been developed to boost their efficacy or to help with the targeting so that the immune system can find the cancer cells in a more effective and efficient way. So there are antibodies that have been developed that target the cancer cells and sort of raise a flag to the immune system so that the immune system knows to attack those cells. There are things called checkpoint inhibitors that basically work against a cancer's ability to sometimes use natural pathways that slow the immune system down or make it ineffective at treating that particular cancer. And so you'll see a lot of different new medications that are immunotherapies that can be very effective at treating certain lung cancers. This has been an area of active research in large part because the side effects of immunotherapy are often thought to be, and actually are, oftentimes much better tolerated than traditional chemotherapies. When patients actually are diagnosed with a lung cancer, sometimes they'll hear the word targeted therapy. And this usually is in reference to the way in which lung cancers, like other cancers in the body, oftentimes have particular mutations that have particular medications that can be used now to target them. One example is EGFR mutant lung cancers. So EGFR is a protein on the surface of cells that helps with growth and the division of regular cells. Some lung cancers have an overactivation of this particular gene, so they grow faster and unchecked. And we now have medications that can target this particular pathway and can be very effective at treating cancers that have this type of mutation. Oftentimes when someone is a never smoker or has never had other risk factors for developing lung cancer, sometimes we look particularly closely to see whether or not they have some sort of mutation that led to their cancer developing because that may mean that they're more eligible to receive targeted therapies like this. The side effects for targeted therapies are oftentimes better than chemotherapy as well. The challenge with targeted therapy is that they often work really well for a while, but then sometimes the cancer develops new mutations that help them move around this type of treatment. So I wanted to discuss, since it's so pressing in all of our minds and lives right now, what it is like if you have lung cancer in the course of this pandemic. And my only advice would be to really try hard not to postpone your appointments or treatments for lung cancer. On the one hand, we really don't know, while we have vaccines that will hopefully be coming early in the new year, we don't know how long COVID will be around. And so I wouldn't recommend just waiting and saying, I have lung cancer, but I want to wait till things are safer, because we don't know when that safer will be. During the COVID-19 surge here in New York in March and April of earlier this year, we did cancel some surgeries for a while, but many still proceeded. And we tried hard to make sure that lung cancer treatment wasn't postponed indefinitely, because that time is really time where a cancer can potentially continue to grow or spread. And so I think it's definitely, if you're faced with a diagnosis of lung cancer and we're still in this lockdown type mode, it's important to have this type of conversation with your physician and to really figure out the risks and benefits. Treating cancer is in a prompt manner is very important to an oncologist like myself. And we'll work through this to make sure that things are as safe as possible for you, the patient. At New York Presbyterian and New York Presbyterian Queens, we certainly work to minimize the number of visits that you'll need to make to the hospital. We do a lot of our communications with patients via telehealth now and Zoom conferences, just so that you don't come into the hospital just for a quick visit if you don't need to. And when you need surgery, you're tested for COVID-19 in advance, and you're kept in rooms that are separated from patients who are actively being treated for a COVID-19 infection. Can lung cancer come back if you've been treated for lung cancer? Yes, lung cancer can certainly come back. And one of the main risk factors, as I mentioned before, is that if you had a lung cancer previously, you're at a higher risk than the general population for developing a new lung cancer. And that's why after treatment for lung cancer, surveillance is a very important thing that we do. We generally survey for lung cancer with regular appointments, anywhere from 6 months to every year. And this is done either with medical oncologist or your surgeon, and it's done primarily with CAT scan imaging. Regular visits are important so that if the lung cancer returns, it can be treated early, sometimes either with another surgery or other medications or radiation therapy. A lot of people ask me, what can I do to prevent lung cancer? And unfortunately, the reality that I think it's actually somewhat important to recognize is that lung cancer cannot be prevented. We can decrease the risk of lung cancer. We can catch lung cancer early. We can even cure lung cancer. But to imply that it is preventable actually gives us a little bit of a problem. To imply that it's preventable has actually fostered a little bit of a stigma towards lung cancer that has worked against the community of those who are facing lung cancer. There's a lot of patients who are diagnosed with lung cancer get a sense of blame or guilt, and there's even been a lack of research funding for lung cancer. And in large part, this has been because of the downsides of very effective public health and smoking cessation campaigns that occurred. They were very effective at helping spread public knowledge that smoking increases the risk of lung cancer, but then it also sort of cast a little bit of blame to patients who were faced with a diagnosis of lung cancer. And it's important to sort of, I think here is where words matter a little bit, because no one deserves to have lung cancer. And smoking has broad implications for a patient's health in general. It increases the risks of disease, not just lung cancer, but stroke and heart attacks and peripheral vascular disease. And at its core, it's an addiction. And so it's not just a detrimental behavior that is chosen. And so I think it's important to be empathetic to patients, especially as they are facing a new diagnosis of lung cancer. That being said, if someone is smoking, they should stop. They should. There are a lot of tools that we have at our disposal nowadays to help people quit smoking. We should also try to minimize inhalational exposures, exposure to air pollution, radon. We should do regular checkups. If someone is a former smoker, they should ask their primary care physician whether or not they're eligible for screening. Healthy diet, one filled with fruits and vegetables, and regular walking. Walking is great for lung health, is important to try to keep someone in good shape and minimize their risk of lung cancer as well. I want to talk a little bit about e-cigarettes and vaping, especially in this community. I feel like many of you may have either children or grandchildren, and I wanted to at least discuss e-cigarettes and vaping a little bit. Some of the more recent studies have shown that almost a quarter of high schoolers are actively vaping, and close to half, maybe even more than half, have at least experimented with vaping and e-cigarettes at some point. The big question is it safer or does it serve a purpose? It was initially intended, or at least advertised, to be something that could be effective at helping people quit tobacco-related products. The reality, however, though, is that many of the individuals, especially young people who are taking up e-cigarette and vaping, have never smoked. And so the question is whether or not that's actually, it probably is not serving them a great purpose. And when it comes to the risks of e-cigarettes, vaping, juuling, the risks I find are quite high, and they need to be discussed in an open forum. The main thing is addiction. There are high concentrations of nicotine in these formulations. And then the actual risk to lung health is the additives, the flavors, the solvents that are used. Many of them can be irritants to the lung. And there's so many different products out there and available. There's overall a fair lack of regulation to these products, and a lot of different markets where young people, they may not be looking at exactly what they're putting into their bodies. And then there's a long history of research that basically just shows that when an area is chronically inflamed, it leads to scarring and can increase the risk of the development of cancer over time. And so while I would hypothesize that cigarette smoking is worse than e-cigarettes and vaping over the course of time, there's still a lot that we don't know about how e-cigarettes and vaping are going to affect individuals long term. Last year, before the pandemic hit, we heard a lot about e-cigarette and vaping associated lung injury. There were young people otherwise in good health who were showing up in hospitals across the nation, and this was a real concern. Thankfully, that seems to have petered out a little bit. Most of those cases appeared to be linked to THC-containing e-cigarettes, which had a particular additive that was very irritating to the lungs. But at a certain point, there were up to 300 patients a week who were being admitted to hospitals and really receiving a lot of aggressive treatment, and even some dying based off of lung injury from e-cigarettes. And so I think that it's certainly worth a conversation if you see your grandchildren. Most pediatricians are very in tune to this issue at this point. And so if you see your grandchildren or children using e-cigarettes and vaping, I think it's certainly worth having a conversation with them about whether they're aware of the different risks, what products they're using, and what the reason is for their using these products. I'm gonna wrap up now, but I think just to summarize some of the different things that we went over today, lung cancer is treatable. Every patient with lung cancer is different. And so when I'm confronted with a patient with lung cancer, it's important to see not only what needs to be done, but also how treatment for that lung cancer fits in with them as an individual, especially because there are more and more treatment options available nowadays. Treating a lung cancer can sometimes become quite complicated. It involves cancer specialists, lung specialists, surgeons, radiation specialists, and I think it is certainly important to have to find treatment in a place where they have access to those different specialists. It's not really something where you want just a single person oftentimes managing all of the care. It's oftentimes that someone should play the quarterback, but it really should be a group multidisciplinary type discussion for the treatment of most lung cancers nowadays. And then finally, if you are over 55 and have smoked heavily in your life, certainly please ask your primary physician or a lung specialist like myself whether or not you're eligible for lung cancer screening. And I would certainly encourage you to receive that type of screening. With that, I think we may have some questions. I'm not exactly sure how this is going to work. I left my email up there, and if you have specific questions, you're more than welcome to reach out to me directly. And please stay safe, everyone.
Okay, thank you so much, Dr. Chow. That was extremely informative. We have so far just a couple of questions. Okay, so one actually, it's about somebody who actually right now has lung cancer, and they feel that this person is not in a high risk category for COVID. But the question will actually really involve everyone. And we had heard from another doctor a number of weeks ago, but let's hear your opinion. This really, I think, is whether a person has high risk or not. So this person is saying that they haven't met with their children indoors since the beginning of the pandemic. Now with the winter weather, it's much harder. So as a physician, what is your view of having dinner indoors, but wearing masks, I guess, except when you're actually eating, keeping social distance and keeping the windows open? Do you think that that's still safe?
Yeah, that's a really good question. I think that we're all sort of trying to figure out the best approach to dealing with this. And I mean, the weather's colder now, and so open windows for all dinners might make for very uncomfortable dinners. I think it's hard to set sort of broad, sweeping sort of recommendations in this realm. Personally, my personal approach is that I think that large gatherings should still be basically not taken at this time, especially as we start seeing an uptick in cases and positivity rates across the country. I think that's a little easier to explain and recommend to people here in New York because we saw how devastating COVID was and we experienced it so heavily here. When it comes to individuals who have had prior lung operations or who have a lot of breathing related illnesses, I think it certainly is worthwhile to take that extra little bit of caution because we know that they're receiving or acquiring a COVID infection might have worse outcomes. And so it's hard to say just don't see your children or your grandchildren, but I think deciding whether or not to have a dinner in that sort of forum is tricky because it depends a lot on, are there children going to school? Are they likely to be acquiring the infection themselves? The community spread is still hard to pinpoint in terms of what the risk is from one school to the next. And so I think that caution especially is certainly in order. And especially because maybe we've dealt with this for 9 months or more. And it may just be several more months before we receive and start to see the impact of the vaccines that are showing some promise. It's still going to be a while because we still need to see the approval and the implementation of these. But I think that it is something that we are expecting down the line.
Okay. There's one other question here. If anybody has anything else, please put it in the chat very quickly. Okay, so somebody poses a hypothetical case. A 6 millimeter nodule in a lung was discovered in the CT scan of the heart, and it confirmed more clearly in the CT scan of the chest and lungs. The protocol advises another scan in 6 months, at which no change was detected. Then another scan in 12 months. Are the 12 months adequate? Does that make sense to you?
Yeah. There are actually, I'm sorry, someone trying to say something?
No, I'm just saying, is the 12 months adequate? That's what the person.
It can be. So there are actually a set of guidelines called the Fleischner guidelines, which radiologists and cancer specialists adhere to. And there's a lot that goes into some of these decisions as to how frequent to image a nodule or an abnormality in the lung. We try hard to not image people unnecessarily, and because the lungs change over time. Sometimes people get little tiny infections. Sometimes there's some mucus that can appear a little bit abnormal. But we have to factor in a patient's risk factors as well. And so generally, as long as, so that what you're describing in that situation is a sub-centimeter abnormality, nodule presumably. In most situations, even in higher risk individuals, the recommendations for an initial scan would be 6 months. And then if there's no change or if it has receded in size, which is something that would be unusual for a cancer to do. A cancer generally keeps sort of steadily growing or not changing much. The timeline for that next scan is extended. In certain very high risk individuals, the clinicians who are actually looking at the images and the radiologists who are actually looking at those images might deem that there's a characteristic of this nodule that looks particularly abnormal, or I'm worried about this patient because they've had a prior cancer. And in those situations, even though there are those guidelines that might say it's okay to wait a year, they might choose to get a CAT scan with a shorter time interval. So I think that as long as someone's looking at those guidelines and who is familiar with that patient's particular care, I would say that that may be a completely reasonable thing to do, to be waiting for a year. But again, it needs to be someone who's actually looking at those images and knowing that patient.
Got it. I don't see any other questions here. So I want to thank you so much, Dr. Chow. It was extremely informative and very helpful. Everybody, of course, will be getting, I'm sure people will want to review what you said. Plus, as I told you, we have people literally around the world that listen for these programs. So everybody will be receiving the recording later, hopefully later on today or early tomorrow morning. And I know that there were some other materials that, some contact info that the hospital provided. So that'll go out with the recording. We again want to thank New York Presbyterian Hospital of Queens for these very, very informative sessions. We have another one coming up in another few weeks, which you'll all get information on. So I only have a couple of announcements. On Thursday, we will be very honored to welcome back Faye Wilbur, LCSW. She's spoken for us a couple of times and she's always been very, very popular. She will be addressing creating healthy and functional relationships. So that'll be Thursday. You'll be in the email you get with this recording. Of course, we'll get the registration. I want to remind everybody that the Spirit links, the recording links that I sent out prior to 2 weeks ago, I think it was starting November 1st. Anything that's before November 1st will not work anymore. We've changed our account and those links have expired. Not to worry, every single session is in the archives. So, and the link to the archives is in all of the recordings all of the emails that you get. So all you have to do is visit the archives and just search for anything that you want to see, and it's there for you at your convenience. Have a wonderful day, everyone. Again, thank you so much, Dr. Chow. Chodesh Tov, should be a wonderful month, Kislev with Hanukkah in it. Be safe and healthy, and we will see you on Thursday. Take care, everyone.